This is chapter 4, recording number 6, and this will actually be the last recording for this chapter. We've already talked about the role of medical control a few times now. You've either got offline, indirect, which is our protocols or our standing orders, or it may be online, so you're actually directly controlling or contacting them. Medical control does not necessarily mean that you're talking to your medical director for the service. This means you're calling into a physician at your receiving hospital the majority of the time. It depends on how your protocols are written as to when you need to call medical control for direct orders. There are some times that we always have to call medical control. In your protocols, they may say that you have to call them before administering certain treatments. This definitely becomes more prevalent when you get up into a higher echelon of care. So paramedics oftentimes, in order to give certain medications, have to call and talk to medical control. Determining the transport destination of patients. Here in South Dakota, that's typically not an issue because we aren't going to be transporting to a lot of specialty hospitals. Really what we have is out in the smaller communities, we have critical access hospitals that we're going to transport to. Here in Sioux Falls, we have 2 level 2 trauma centers. It really doesn't matter which one you take, either two, because we tend to have that pediatric castle at Sanford. Critical pediatrics more often than not tend to go to Sanford, but that's not necessarily a rule. We don't have a burn center, so most of our patients come into either hospital and then get flown to either Minneapolis or up to Fargo for burn control. There's a burn unit that's in North Dakota as well that's not as often that we fly to. But there are stroke centers, there are cardiac centers, there are severe trauma centers, there are surgical centers in some of these larger cities. We don't have it, but sometimes your medical control will help you determine that if you're not quite sure which place to go. Contact them on stopping treatment or not transporting a patient. We talked about having those difficult patients that just don't want to go, but you have a gut feeling that you cannot leave this patient. If you seriously feel terrible about this, you can always call medical control and say, hey, this is what I've got. The patient is refusing transport. Is there anything that I can do? Anything that I can say? And they might give you some ideas. Or if you've already treated a patient appropriately, they may be okay with saying, hey, no, don't transport. You're going to document that you called that physician, what their name is, what facility that they're at, and the advice that they had given you, because that means that you didn't make this decision on your own. It actually puts that back on the physician. Stopping treatment, this is typically going to be on our CPR calls when we have done everything humanly possible and we've gotten no response out of the patient, which truthfully happens more often than you would think. We're kind of taught in CPR class that you do CPR and everybody lives, or at least the majority of people live. In the out of hospital setting, that's not true. We lose people more often than not because they have unknown downtimes before we get to them. The longer you lay, the less likely it is that we're going to save you, and most of our response times are anywhere between 5 to 8 minutes. So laying there for 8 minutes, and that's after somebody's found you, not exactly the best situation for survival. So oftentimes we'll go on a cardiac arrest. Depending on your system, you may or may not transport a cardiac arrest in the field to begin with, to start treatment. Oftentimes we have more people on the scene that we can give a more effective care, more effective CPR than trying to get in the back of our ambulance where it's very closed in. We can get maybe 3 people in the back. And so my service's protocol was we don't transport dead bodies. So if we're on scene and we manage to get a rhythm back or we shock, that's a lot different. You actually see a response in your patient and then you're more apt to transport. There are some services that transport pediatrics irregardless of their condition. So my service was not that, neither of the services I've worked for. Um, Adults and pediatric patients were treated exactly the same. In most areas, medical control is provided by physicians working at the receiving hospital. If you have two facilities to go to, such as here in Sioux Falls, pick one. The one that you are going to take the patient to. You can always ask them, hey, which hospital would you like to go to? If they're unconscious, pick one. Here in Sioux Falls, patient care EMS does kind of have borders of, if somebody's over here and doesn't have a preference, we take them here. If somebody is over here, doesn't have a preference, we take them over here. Not all services are like that. When I was out in Montana, we had two facilities. Both of them were level 2s, and they were about 3 blocks from each other. So pick one. Normally, if we had back-to-back calls or we had one unit that was already going to one hospital, you'd pick the other one. So you call in dispatch and say, okay, which hospital is next on the rotation? And that's where you would take the patient. There's many variations that have developed across the country because we typically were using ER physicians, but that's not the case anymore. So it kind of is what works for our system. You have to have a link to medical control to provide high quality care. Our protocols are very, very comprehensive, but even with that, patients do some pretty crazy things, either trauma-wise and get hurt, or just medically. The body doesn't always work as the textbooks say that it does. So having that backup so that you know what your options are is definitely vital. Calling medical control, there's a number of ways. Some services that still use radio communication will have a different channel for ambulance to hospital communication. The hospital always maintains on that channel, and EMS will just flip over to it. Keep in mind that this generally is not the same one that you talk to dispatch on. If you can keep one radio on your dispatch and one radio to the hospital, typically the one that's up by the driver is going to stay with dispatch. The one in the back is going to be the one that you're going to flip to the hospital channel. You need to make sure that you flip it back after your call. You'll typically leave it on the hospital channel throughout the rest of your transport in case the hospital wants an update. The dispatcher monitors and assigns appropriate and clear medical control channels. And then you typically have dispatcher resource coordination centers as well. Oftentimes these are going to be combined. I know at the first service that I worked on, they actually took the entirety of the dispatchers specifically for that service and put it out of a call center that was actually in Seattle, and we were in Montana. So we had those dispatchers that dispatched our calls, everything like that. And then we had local dispatch, which controlled fire, police, and all of our other services. And so we had two dispatchers that we often talked to. And it was interesting, but we made it work very well, I think. The physician bases his or her instructions based on the information that you provide them. So when you call up, you're going to give essentially another report, but you say, hey, this is the situation that I'm in right now. This is the background. It's called SBAR. This is the background. Here's the actions that I've taken, and then here's what I'm requesting. I need information on this. I'd like to give this medication. What do you think? Or I'm shooting in the dark here. Please help me. Never use codes with a physician unless directed so by your local protocol. Oftentimes we use 10 codes because they're a lot faster way to communicate. 10-4 being yes, I acknowledge. That's part of the 10 code that kind of gets leaked out into the public, but there's a whole comprehensive list of 10 codes. Don't use those with the physicians. That's not generally part of their training. So talk as plainly as possible. Repeat your orders back word for word. So if they say, yes, go ahead and give this much of this medication, or yes, go ahead and discontinue CPR, you'll say, okay, I understand that I am okay to discontinue CPR, correct? And they'll say yes. Always, always, always repeat back what you believe that you heard, even if it's just super simple. Always. Don't blindly follow orders that don't make sense to you. If you get that gut check moment that's like, something here just isn't right, make sure that you say something. If you end up not following a physician's orders, you need to have a darn good reason for it. Typically, you have to challenge the order first and say, hey, are you sure? Most services have a 2-challenge rule. That's something that the NREMT is doing as well. So challenge the first time, challenge the second time, and if they give it again, then you know that you've done your due diligence. Information regarding special situations. You may need to initiate communications with hospitals to let them know of extraordinary situations. Some of these would be a rural hospital. If you have multiple patients in a highway crash, if they are notified by that first ambulance that's responding, then they can start pulling staff to make sure that they can take care of everybody else. Hazmat situations, we are not going to be driving into a hospital without at least letting them know about a hazmat situation, because they're going to need to decon the patient. They need to do certain things to keep their staff safe. If we're doing a rescue, we're going to typically let them know, because that means that our patient care is going to be delayed, and there are certain things that they're going to prepare for. If we're doing a water rescue, they're going to prepare for more like hypothermic situations, potential drownings, needing to control an airway. So they'll have bear huggers, which is this big, huge sheet that has holes in it that face the patient, and they put up a basically heater that blows hot air to that. Definitely helps warm patients up. They can get warm IV fluids so that they warm from the core out. Having respiratory therapists there to control an airway if need be. So it's definitely a good idea to contact them ASAP if there's something that's out of the ordinary. Keep several points in mind. The earlier the notification, the better. This also works if you know that you're probably going to launch the helicopter based on what you're seeing. What you can do, instead of actually launching them before you see the scene, you can put them on standby so that they notify the crews. They can get up to the helicopter and do their checks, so that if you do need to launch them, they can just lift off, rather than then having to go up and do all these checks, and it ends up extending the time before they respond. So that's a good use of that system as well. You need to provide an estimate of the individuals that need to be transported to the facility. So you know that you're letting them know, hey, we're coming in with 5 potential patients. That way they can pull more supplies, more people if they need to. If there's any special needs of the patient, burns especially, they need to get a bunch of people together for that. So follow your systems plan. They typically have plans for MCIs, for hazmat situations, for burn patients, so that you guys can know what's going on. Maintenance of radio equipment, it's like everything else, just like our EKG monitor in the back of the rig. We definitely have to service it and make sure that it's able to work properly. Your radio is going to be your lifeline. So that's one thing that you need to make sure works, that you should be testing it every shift as well. Radio equipment may fail during a run, so you must have a backup plan. Typically, the radios that are in the truck, the backup plan is the portables, and vice versa. Oftentimes, there's a cell phone number that we can call. This may include standing orders, their written documents. And sometimes you're just going to have to roll with that. You may not be able to contact medical control. If you cannot contact medical control, you're bound to those standing orders. So when we would go out into the boonies in Montana and we literally couldn't contact anybody, we had to follow our protocols, what we had for standing orders until we got back into service, and then we could call. If we would have had a cardiac arrest in some of those areas in the 5 years I was there, I did not, with that more rural service. But if we would have had to drive either with the patient transporting, or we would have to have somebody go and contact. So kind of a scary thought, but that's what we would have had to do. You do have review questions in your summary that you can certainly go through on JBL. Other than that, this is the end of chapter 4.